am Dr. Pankaj Desai from Surat, and I take this opportunity to thank Dr. Manoj Sahu and his entire team and wish all the best to this midterm endocon, and thank him again for allowing me to deliver this talk. The topic which is given to me is poem myotomy, where, how long, and how. So the basic steps of poem is a mucosal injection, incision, entry into the submucosal tunnel, submucosal tunneling, doing a myotomy, assessment of completeness of the myotomy and securing hemostasis, and then closure. What we are going to discuss is only the myotomy part of it. In very brief, we will just see the steps of poem. This is the submucosal injection, then the incision, then entry into the tunnel, doing submucosal dissection, separating the mucosa from the muscle, separating the mucosa from the muscle here, and then completing the tunnel 2 to 3 centimeters inside, assessing it from the retroflexion of the scope, and then doing a myotomy, which is our primary aim of discussion today. The myotomy can be a circular myotomy, as you are seeing here, or you can do a full thickness myotomy, as you can see here. Once it is complete, assess the depth of myotomy, assess the completeness, see hemostasis, we come out, and then seeing if the mucosa is intact, we will close the mucosal incision. So we will discuss the myotomy according to the length of myotomy, anterior or posterior, full thickness versus partial thickness myotomy, the technique of myotomy, and where a direction of myotomy. So first, the length of gastric myotomy. This we are discussing first because there are a few important facts which are already known about the gastric myotomy, and the facts are that gastric myotomy, if it is more than 2 centimeters, is associated with increased incidence of GER. So accurate estimation of the length of gastric myotomy is very important. Longer the myotomy may predispose to GER, shorter myotomy may result in recurrence and dysphagia. Therefore, Inouye, in his article, in his title of presentation, Multicenter Collaborative Retrospective Review of Poem, in 2018 in the SAGES guidelines, has told that a more than 4 centimeter myotomy on the gastric side is associated with increased risk of erosive esophagitis. And therefore, the length of myotomy on the gastric side is recommended to be 2 to 3 centimeters. So this is proved beyond doubt that you have to do only a 2 to 3 centimeter myotomy on the gastric side. Now, for the esophageal length of the myotomy. This is dependent on the indication, and it differs in different types of achalasia and other spastic esophageal motility disorders. So the advantage of poem in this aspect over LHM or open Hellers is that the length of myotomy on the esophageal side can be tailored depending on the indication. HRM or high resolution esophageal manometry is the investigation of choice. Now, where we have to do a myotomy or where we do in poem is it's all type of achalasias, excluding tertiary achalasia, which requires esophagectomy, esophageal motility disorders with symptoms dysphagia or chest pain, diffuse esophageal spasm, nutcracker or a jackhammer esophagus, hypertensive ileus, or non-specific esophageal motility disorders. Now, this is the latest Chicago classification, the 4th edition, and they have classified the dysphagia into disorders of EGJ outflow obstruction or disorders of peristalsis, and we have type 1, where we all know that there is abnormal IRP and 100% failed peristalsis, type 2, where there is abnormal median IRP, failed peristalsis, and more than 20% of the swallows showing pan-esophageal pressurization. Type 3 is again same, median abnormal IRP, more than 20% with premature or spastic contractions and no peristalsis. While EGJ outflow obstruction is abnormal IRP, supine or upright, more than 20% elevated intrabolus or pressure, supine, and not meeting the criteria for achalasia. While we can do a poem in this disorders of peristalsis where we have DES, where IRP is normal, and we have 20% or more peristalsis showing premature or spastic contractions, and a jackhammer or a hypercontractile esophagus with 20% of swallows showing a hypercontractile swallows. Now, coming to each type of achalasia and the length of myotomy that we can tailor. Type 1 achalasia, as you can see here, there is no problem in the esophagus because the motility is not there. So doing a myotomy on long myotomy on the esophageal side is not going to help, and therefore what we do is a small myotomy, a 6 to 8 centimeter myotomy on the esophageal side, and a 2 to 3 centimeter myotomy on the gastric side. Type 2, you have pan-esophageal pressurization, and therefore where you see a contractility in the esophagus, we do a little longer myotomy. So the myotomy would be around 8 to 12 centimeters on the esophageal side. Type 3 or the spastic achalasia is the least controversial one in regards to whether you have to do a POEM or do an LHM, because it has been proved beyond doubt that in type 3 achalasia, the POEM is more efficacious than LHM. And here the length of myotomy can be tailored as long as possible to involve the most proximal contraction. Here you have big contractions, and the hypercontractile part of the muscle, if it is not included in the myotomy, the patient will not have relief from the symptoms. So this is the study which has been done by Vivek Kumbhari and published in Endoscopy 2015, showing that LHM versus POEM in type 3 achalasia, you have a longer length of myotomy which is achievable with POEM, very few adverse events, and a very good clinical response to the tune of 98%. Next, in the jackhammer esophagus, the length of myotomy must be tailored as long as possible to involve the most proximal trough you can see here. So if you do a short myotomy, the patient will continue to have episodic pain and symptoms. So whether, and the important aspect or the point of debate in a jackhammer esophagus is if you have to do a myotomy across the G junction or not. That is controversial, but what we can do is, if you have a high IRP and if you have a spastic distal esophagus, you can extend the myotomy across the G junction. So this is how it goes for jackhammer esophagus. Now, when we come to whether you have to do an anterior or a full thickness or a partial thickness, we have to have some technical considerations which are seen here. Now at the G junction, we have two types of fibers. On the right side, you have this clasp fibers, and on the left side, you have this sling fibers. This is very important to understand, and why, that I will discuss later. Next, full thickness or a partial thickness. This diagram is showing you that we have an inner circular muscle in the esophagus and an outer longitudinal muscle. So whether you have to cut both or not, that also we will discuss. First, anterior versus posterior. As you can see here, if the patient is lying with the head on this side, we have to tailor our myotomy for a posterior myotomy around 2 o'clock if you are doing an anterior, and if you are doing a posterior at 5 o'clock. It has to be on the right side. This is a very important message, and why, that I will discuss. Again, head end is here. If you do a myotomy, anterior myotomy, it has to be at around 2 o'clock, posterior at around 5 o'clock on the right side. Very important. And we have three good papers which are showing. One is from India for anterior versus posterior. This shows from Mohan that you have increased acid exposure and increased Demester score if you do a posterior myotomy. But this paper from Tan in GIE in 2018, it is showing that anterior and posterior is same in all regards. There is no difference with anterior and posterior. Again, this last paper which has come just in 2020 by Khashab from John Hopkins, and they have concluded a 2-year follow-up post-procedure for anterior versus posterior, and they concluded that the anterior and posterior POEM techniques remain equally effective at 2 years and have a similar decrease in efficacy over time. GRD outcomes were similar between both groups and during medium follow-up, and therefore again, no difference anterior versus posterior. So anterior or posterior, you can decide depending on how comfortable you are doing an anterior or posterior. Full thickness versus circular, one good paper. There are other few papers which have very few number of patients. And so this paper has shown that a mean operative time was significantly shorter in a full thickness myotomy and compared to the circular muscle myotomy, but there is no increase in any procedural related adverse event or whether you do a full thickness or a circular. So this again, you can do either a full thickness or a circular depending on your choice. Now, how to do it? This is very important. For the circular myotomy, my preference is, what I will do is, we will start 2 centimeter below our mucosal incision, go inside, and first we will expose the linear fibers. So you do a circular myotomy layer by depth and go into the depth where you are start seeing the longitudinal fibers. Once you see this longitudinal fibers, what we have to do is hook this knife in between the longitudinal and the circular muscle fibers, and then slowly go up and cut only the circular muscle fibers. And this step has to be repeated very carefully so that knife doesn't touch the mucosa on the top. For a full thickness myotomy, what we do is introduce the knife in between the longitudinal fibers, go deeper, just deep into the longitudinal fibers, separate the longitudinal fibers, find the plane just below the longitudinal fibers, and then repeatedly hook the knife, lift up so that you don't damage the structures in the posterior or the anterior mediastinum, and then do a full thickness. Here there is less time is taken, as the plane, you already have a very good plane for putting the knife inside and doing a full thickness myotomy. So this becomes very fast. Now, very important is the direction of cut, and here we have to understand why we do the cut on the right side. So at the G junction, we have two types of fibers, the clasp fibers and the sling fibers. The clasp fibers have a high basal tone. Acetylcholine they contract while nitric oxide causes relaxation, while the sling fibers have a low basal tone. They again contract with acetylcholine, and nitric oxide is absent in this. In achalasia, the nitric oxide fibers are absent, and therefore the LES, increased tone of the LES, is because of this absence of nitric oxide fibers. So if we cut this sling fibers, then the tone of the LES would decrease and we will have reflux. And therefore, in our PROM procedure, we have to cut only the clasp fibers to relax the LES and not the sling fibers. And therefore, we have to tailor our myotomy onto the right side. Now, there is one more study from Tanaka which has shown a very important aspect, that whenever we go across the G junction, dissect around 2 to 3 centimeters, we come across these two perforating vessels in majority of the cases. Taking this as a guide, what we see is, to the right of this vessel, these are the clasp fibers, and to the left we see these are the sling fibers. This we can confirm by doing a double scope technique also. So our myotomy across the G junction into the gastric side has to be on the right of these two perforating vessels and not onto the left. This way we can salvage the sling fibers, and this study from Tanaka has very elegantly demonstrated that if you use this as a guide, do a myotomy posteriorly on the right side, we have very few symptoms of reflux, and esophagitis drops down to almost half, which is statistically significant. Now, if you don't see the vessels or see the vessels in a Silhouette, this is a real life example of what we see. You can see this vessels in the Silhouette. You are not seeing it very well, but you can see these are the sling fibers. You can see these are the clasp fibers. So again, you have to remain on the right side when you are doing a posterior myotomy, and that will save you and the patient from a lot of reflux. This is something which is very important regarding the direction of the cut. Now, how to assess the completeness of myotomy? Endoscopic evaluation, just by crossing, you will see that the resistance has gone. Go into the stomach and doing the retroflexion, we will see that the G junction is open around the scope. Very important is the double scope transillumination technique, which is the best modality to assess. And if endoflip is available, it is also a very good tool for measuring distensibility index and the pressures after POEM. This is I feel the most effective tool, which so far is not very easily available in India, and we are not doing this. But if it is available, this will alter the recurrence rates in a poem, because this is very important. Double scope transillumination, as shown by Haru Inoue, is the most reliable method to confirm the length and direction of the myotomy when observing the gastric cardia. So we have to put a thin scope into the stomach, and we can see this on retroflexion, that the scope, if you can see the light, it is confirmed that you have crossed the G junction and you are into the G junction. So this is the length of the gastric myotomy, as you can see here, from this scope to this scope. So this is the best method of detecting the completeness of myotomy. So in conclusion, I would like to say that tailor the length of the myotomy according to the indication. Esophageal myotomy, gastric myotomy restrict to 2 to 3 centimeters. In type 3 achalasia and Jackhammer, long myotomy is essential. Anterior versus posterior, similar efficacy and reflux, and therefore it depends on your choice. Only a circular myotomy or a full thickness myotomy having similar efficacy and incidence of reflux. So operating time is less in full thickness. So you can choose short myotomy, not more than 3 centimeters on the gastric side, and keeping the direction of the cut towards the right. That is 2 o'clock if you are doing an anterior, 5 o'clock if you are doing a posterior. Cutting the class fibers, sparing the sling fibers is the key to reducing the incidence of post-procedural poem reflux. Thank you for your kind attention, and if there are any questions, I would like to take them.
So as you can, we just heard a very nice talk by Pankaj on the technical aspects of the poem procedure, and the talk which was given to me is regarding this new technique of poem with fundoplication. Is it going to lead us to the future? So this is what I'm going to talk about. I need not stress or emphasize on the point that poem is now already an established. It's better if some places are muted because there's a lot of sound coming. So all of us know that the poem procedure is now an established technique for the treatment of achalasia cardia. And there are many centers all over the world, as well as in our country, who perform the poem procedure quite effectively. It's more than 10 years of evolution, as you see here. The brainchild of these two geniuses, Pankaj Pasricha initially, followed by Haru Inoue, who first did it on the on the human beings. And till date, there are more than 400 publications on poem, with more than 12,000 procedures of poem probably performed all over the world. In fact, you see here, what is the latest status of poem as compared to a laparoscopic Heller's myotomy. This is the latest multi-center randomized trial, which was published from 8 European centers. And it clearly shows that clinical success of poem is very well matching with a laparoscopic Heller's myotomy. All of us have to understand that we are actually comparing a procedure of poem with a procedure which also includes a DORS fundoplication, which is a LHM. Now, with this, you see also that serious adverse events of poem are much lesser than a lap Heller's myotomy with DOR. The only problem which this paper shows us that with poem, you're likely to have increased incidence of abnormal acid exposure and reflux. At 2 months, interestingly, the poem reflux was seen in 57% as against 20% in LHM. Whereas in 24 months, when you followed these patients for 2 years, this reflux incidence after poem has in fact reduced from 57% to 44%. And in LHM, it has increased from 20% to 29%. So now we have to just carefully see these statistics, very, very important when we start talking about this. So in fact, because of this problem of reflux, as it is, all of us know that when we started performing the poem procedure, there was a tremendous amount of reaction from the surgical colleagues. They felt that what you're doing is not proper. We are not doing a proper procedure. And because we are cutting the LES, we are not adding a fundoplication with the poem procedure. it is going to really create trouble in the future in the form of GERD. In fact, you see here in 2017, 7 years after the introduction of POEM, the editorial was published by Thomas Roche in Endoscopy, which actually stated, will reflux kill the procedure of POEM? And this was the status in 2017. Keeping that in mind, it was in 2017 itself that Michel Kahale came up with this new technique, new idea, that in those patients who did develop reflux after POEM, he added a transoral incision-less fundoplication, and he published this paper, you see here, in 2017. And this probably was going to be an answer for these patients who presented with GERD after the POEM procedure. Keeping the same thing in mind and preventing innovator of the POEM procedure itself, Haru Inouye, came up with this very, very unique notes type of procedure for GERD after POEM. And he, in fact, advocated that why not try to do a procedure which is similar to a Lap-Hiller's myotomy and a Dor fundoplication at the same sitting. So he came up with this idea that he performed an anterior tunneling, and then below the lower esophageal sphincter, below the diaphragmatic crura, he went full thickness outside the esophagus, and through the visceral peritoneum entered the scope with the scope inside the peritoneum in the abdominal cavity, where he could actually see the liver and he could see the fundus of the stomach. And then he can pull the fundus of the stomach inside and attach the fundus of the stomach inside the tunnel by a loop and a clip technique. Everybody thought that this new procedure, which Haru Inouye is now described, is now going to completely solve that problem of GERD after POEM. And now we have found now a complete replacement of Lap-Hiller's myotomy and Dor's fundoplication. Well, in fact, if you go to see, this is how that procedure was done. These are the few technical steps of POEM with fundoplication. A few very important things which you need to remember is whenever we want to perform a POEM along with fundoplication, it becomes mandatory that we do an anterior tunneling technique, because posteriorly you can't enter the peritoneum. So you have to mandatorily do an anterior tunnel. Second, it's very important, at least in the lower esophagus, you have to do a full thickness myotomy, without which you will not be able to go across outside the esophagus into the peritoneum. Third, you have to go at 11 o'clock approach, because that is going to be the most safe approach to enter the peritoneum. You have to acutely angulate the scope upwards. Very, very important step in this technique is to identify this phrenoesophageal fat pad, because this phrenoesophageal fat pad is just below the diaphragmatic crura. And this is exactly the identification mark that you have gone beyond the diaphragmatic crura. And then when you go beyond the esophagus, you'll enter the peritoneum. Let me tell you, in the early series, our own series, in one of our patients, we did not identify properly this phrenoesophageal fat pad, and we went anteriorly, and inadvertently our endoscope entered the chest instead of entering the peritoneum. And this, we had to abandon the procedure. We had to put in a chest drain. So this can become a disastrous complication. After identification of the phrenoesophageal fat pad, we have to do a gentle dissection of this fat pad using a coag grasper, then cut this and enter the visceral peritoneum. After which you have to catch the fundus in a practice pass, pull the fundus inside the tunnel and see on a double scope technique whether the fundus is getting rotated and you are actually creating a fundoplication. And after this practice pass, you can attach a loop to the fundus with 4 clips, which is a hemo clips, and then pull the whole fundus inside the tunnel. And the same loop is attached to the cut edge of the muscle inside the tunnel. And then we close the loop. With that, what happens is the fundus gets pulled actually inside the tunnel, and thereby it looks as if we have performed a fundoplication. Just to tell you how this procedure is done, technically, this is how we are performing the anterior tunnel now. We are going somewhere at 11 o'clock or 12 o'clock position. The patient is in a supine in the left lateral position. You see here, the tunneling is complete. And once the anterior tunnel is completed, the second step now is to do the full thickness myotomy. So this is how we do the full thickness myotomy. We need not do the full thickness myotomy in the entire length, but it's most important to do this myotomy completely, especially the lower end. Ideally, you should be able to identify the diaphragmatic crura and then the phrenoesophageal fat pad. Sometimes this may not be possible. And in that case, there will be misidentification of the structures. However, once you have identified this phrenoesophageal fat pad, then you have to slowly angulate the scope upwards towards 11 o'clock direction, and then you have to start nibbling on that fatty tissue. And after doing that, we will start seeing the visceral peritoneum. And then once you see the visceral peritoneum with the coag grasper itself, we open the visceral peritoneum. The visceral peritoneum is usually transparent. You can see beyond it the liver which is moving, and thereby you can see you are cutting the visceral peritoneum now. And then we can enlarge the cut in the visceral peritoneum by using an insulated tip knife so that you don't damage any structure outside. Then we cut further so as to enter properly inside the peritoneum. And then once we enter inside the peritoneum, on the right side, you can see the left lobe of the liver. On the left side, when you angulate the scope to the left, you start seeing the fundus of the stomach. So this is the fundus of the stomach. So now this, we are going to grasp by means of a grasping forceps. This is a special forceps which we use for transgastric balloon extraction. This is a very good forceps to do a practice pass. So we are catching the fundus and we are pulling this fundus inside the tunnel. And as we are pulling it with the double scope technique, you can see transluminally how the fundus is getting pulled and twisted laterally, and thereby we are actually creating a fundoplication. Now, once we know that this is the right place to attach the loop, the next step is going to attach the loop on the fundus of the stomach. So we are carrying the loop alongside of the scope, and along with the clip is already put. Then we go in, we open the clip, and we attach the loop on the fundus of the stomach. So this way, to make it secure, we apply 4 clips, and then the same thing is pulled back. The whole scope is pulled back along with the loop, and the loop is then attached to the edge, cut edge of the muscle inside the tunnel. So here what we do is, this is how we are attaching the loop. And after the loop is attached, we have to cut the loop, the extra loop which is there, and then we have to bury that loop inside the muscle so that this loop does not create a perforation in the mucosa inside the tunnel. So this is how the fundoplication is actually created. And you see here now that once that fundoplication is created, this is how it looks. By putting a scope inside the lumen, you can actually see as if it looks like a surgically created Dors fundoplication. Well, endoscopists became extremely excited and they started feeling that now we have found a fantastic solution. In fact, if you see here, Dr. Amol Bape published this paper very, very recently in December itself, 2020. It was published in Endoscopy, where he published his results of 25 patients of a retrospective analysis of prospectively collected data. And he found that POEM with fundoplication was successful in 9 months. Intact trap he could see at the end of 1 year in 82% of the patients with abnormal acid exposure, only 11.1%. Well, this was a very, very exciting result seen from Amol's paper. But unfortunately, I just want to show you this paper, which we published 2 months before Amol published his paper in endoscopy. Our paper was published in digestive endoscopy on 20 patients, again a retrospective analysis, but our results were quite different. If you see here, technical success was good, 85%. But if you see here, within 1 month itself, we found almost 30% of the patients, this wrap had loosened up. Whereas in 3 months, the loosening of the wrap was in 41.2% of the patients. And abnormal acid exposure after 3 months was almost 50%. So almost the same percentage as you see after a POEM procedure, the reflux had again started. And this so-called fundoplication, which we created with a POEM with F procedure, did not last. What was going wrong? There has to be something wrong. Well, if you were to study, this was the reality. So what we actually saw here was, this is 3 months after the POEM with fundoplication. You can see that everything has loosened up. And in fact, we are finding here that the ileus is quite wide open. And at one area, the clips which are there inside the tunnel have perforated into the mucosa. And you can see these clips which are popping out inside the tunnel, where obviously that this was not going to be a long-lasting procedure. We have to understand that the normal anti-reflux mechanism in the human being is not so simple. It is not just creation, just pulling the fundus inside the tunnel and you create a fundoplication. Because the normal anti-reflux mechanism is because of these 6 factors. Number 1 is the basal ileus pressure. Number 2 is the Pinchcock action of the diaphragmatic crura. Now, the basal ileus pressure is basically a
is an issue which occurs during expiration, whereas during inspiration is the pinch-cock action of the diaphragmatic crura, and third is the angle of His, fourth is the GE flap valve, fifth is the posterolateral location of the gastric fundus itself, and sixth is a motility of the esophagus itself. So all these 6 factors are very, very important to prevent reflux in a normal human being. And if you go to see this paper, which was published way back in 2007 by Pandolfino, he studied all the anti-reflux mechanisms in a normal human being, and he found that the most important criteria to prevent reflux in the normal human being is the inspiratory crural diaphragmatic function, not the basal ileus pressure. So the only independent predictor of GRD was this. Now what happens in lap-Heller's myotomy is, this is the mechanism which gets destroyed. That is, the diaphragmatic crura gets destroyed, especially because they cut the phrenoesophageal ligaments. And that is the reason they have to add a dors fundoplication. So actually speaking, you cannot compare the 2 procedures of POEM with a lap-Heller's myotomy. And you're comparing a POEM where you don't do anything for the ileus, whereas in LHM, you're combining with a dors fundoplication. So therefore, what I want to tell you is, this is what the results of dors fundoplication is. If you see here, this is how a normal dors fundoplication is created. And if you were to study the patients after a Heller's myotomy and dors fundoplication in a long term, you can see this 5 to 20 years follow-up in a patient of LHM with dors fundoplication. Look at this result. This is a surgically created fundoplication with sutures. In spite of this, when you follow these patients for a long term, almost 50 to 65% of them start requiring anti-acid medications. Abnormal acid exposure is seen in 50%, symptomatic GERD in 29%, Barrett's metaplasia in 13%, and in some patients even adenocarcinoma. So what I'm trying to tell you is, a surgically created fundoplication also opens up. This we cannot at all replicate or try to copy by doing a fundoplication internally with an endoscope by only attaching the fundus inside the tunnel with loop and clips. So this is not going to work. So, and that is exactly the reason you can see the results in this randomized controlled study. So therefore, the reality today, what I want to tell you in the future is, number one, POEM with fundoplication is technically challenging. The endoscopist has to really properly understand the surgical anatomy. Otherwise, you can create disastrous complications. You will enter into the chest. There will be big vessels there, and you are likely to damage. Patient will have a lot of bleeding. Second, it definitely increases the procedure time and cost. So I'm not sure whether this is going to be a real procedure of the future. Number three, it makes anterior approach mandatory. If you were to see the POEM procedure all over the world, all endoscopists in the world slowly shifted to the posterior tunneling technique rather than anterior, including Inouye himself. And now, because you are including the fundoplication, you have to again switch back to the anterior tunneling technique. This doesn't make sense. Fourth, it cannot be done in a patient who has got a previous lap-Heller's myotomy or a previous anterior POEM, because you have to go through the anterior tunnel itself where there will be fibrosis. Very important aspect is durability of this wrap is tremendous worry. This is not going to hold. Cleft erosion through the mucosal flap is also concerning. And most important fact is, all of us know that after POEM, only 50% patients develop abnormal acid exposure. So if you were to do this procedure in all, you are doing this procedure unnecessarily in 50% of the patients. So therefore, what is the future? According to me, the future is all patients, you go ahead, perform a posterior POEM, keep these patients on a strict follow-up regime with OGD scopy, pH-metry, identify those patients who have got abnormal acid exposure, and only those patients who develop abnormal acid exposure, we should go ahead and perform a more durable endoscopic full thickness plication by various other techniques. And one very important technique is this, and that is the Gerdex procedure or the endoscopic full thickness plication. So what we do nowadays is, all those patients who develop GERD after POEM and which is documented on pH-metry, those who even have symptomatic GERD or those who have esophagitis, we perform this endoscopic full thickness plication, and this prevents the reflux. It reduces their reflux, and therefore we are performing this procedure only in those patients who require it, rather than doing it as a blanket procedure for each and every case where in 50%
you will do an unnecessary procedure with its added risks as well as inadequate durability. What is going to be the future? If you ask me, the future is going to be this. The future is the flexible robotic endoscope. Very soon, we are going to be having such type of a flexible robotic endoscope where we will have two arms, and the same fundoplication procedure we will be able to do if required in those selected patients by passing a flexible robotic scope inside the lumen of the stomach, take a U-turn and perform a proper created fundoplication by taking proper full thickness sutures using these double arms. So this is my take on it, that POEM with fundoplication probably is not going to be the future as a blanket procedure for each and every patient. However, we can do a selective endoscopic full thickness plication only in those patients who develop GERD after the POEM. Thanks for your attention.
That was an excellent talk by Dr. Amit. Now we'll open for questions from the panelists and the chairpersons.
Excellent talk, Dr. Amit. Can I ask a question? So, see, according to your this thing is that it's overdue doing a fundoplication, and even the initial studies says that even these patients who develop reflux are very easily controllable by the PPIs in the initial, the large Italian trial and all those things have shown that. So I want to ask you, when do you really want, which all patients will undergo pH monitoring, and does everybody gets pH monitoring after POEM, or at what interval? How long later will you do it? And then whom will you choose for a GERD-X procedure?
See, what we do is routinely, prophylactically, we do pH monitoring every 3 months, at least for 1 year. And if within 1 year, we don't see any severe abnormal acid exposure in these patients, then we don't have to keep on repeating pH monitoring unless the patient has symptoms of GERD. If the patient has symptoms, definitely we have to do a pH monitoring. Now, if these patients do have symptoms of GERD, we give them a choice whether they want to be on PPI and little lifestyle management. With that itself, if their symptoms disappear, then fine. However, if they can't do without drugs, that means they become PPI dependent. I will not call PPI refractory, PPI dependent. And some patients say, how long am I going to keep on taking PPIs? Only in those patients where we have a documented pH abnormal acid exposure and they have to take PPIs, there we offer them a endoscopic full thickness plication.
Okay, and this you have started up in the last few months or years, right? And
yes.
compared to the pre you must have been doing POEM for so many years now. How it has changed, this approach, how it has changed the overall outcome and the patient satisfaction?
To tell you the truth, in our country, we don't see too much of reflux. See, I've started POEM. I've started POEM in October 2012. In fact, I was the first to do POEM in the country. And from that time, when we started this, only until people started making a noise of will reflux kill POEM, we started thinking about it too much. And we started performing these pH studies, and only those patients, we became a little bit more sensitive, but otherwise it was not required itself.
Exactly, because when you read through those articles, when I read through those articles, there are a lot of fallacies even for the pH monitoring, fermentation process, all kind of things. So I don't know whether really we should go by the symptoms rather than doing prophylactic procedures on all these patients.
Yes.
Exactly, because the fermentation itself causes a fallacious reading on the pH metric.
We have new procedures like ARMA. What do you think those things can be used for control of reflux? Because the valve, the valve might not be so loose in this case when you do a myotomy. So they are very easily done, and maybe more people can, it's not, GERD-X is more commonly available. So do you think that will have a role?
Definitely. ARMS and ARMA will definitely have a role. ARMS may become a little difficult because you have done tunneling in that region. So you may not be able to raise the submucosal cushion for ARMS, but ARMA definitely is possible. Because in ARMA, all that you have to do is just coagulate. ARMA does not require much skill. ARMA, you have to only know where to coagulate. That's all.
And that also you'll have to do how many months after the POEM?
Oh, it depends upon the patient's symptoms. You can do 3 months also. You can do even 3 months later also you can do ARMA procedure. Should not be a difficulty. But you should know exactly where to do it so that you can achieve a proper constriction of the ileus. And I tell you what, very simple thing. Here, you have preserved the diaphragmatic crura when you do a poem. And we all know from Pandolfino study that diaphragmatic crural function is the most important part for preventing reflux. So in addition to reflux, in addition to lifestyle management, start teaching the patient pranayama. When they do pranayama, when they do deep breathing, the diaphragmatic crural mechanism becomes strengthened. That itself will prevent reflux.
You're in the BJP, you're in the...
What are the things which you can do right to prevent reflux in people in POEM procedure? What all can you do to avoid reflux episodes from?
Number one is don't go too deep on the stomach. You go 3-4 centimeters. Don't go too much deep in the stomach. If you start dissecting, you're too greedy. You just keep on dissecting too much, you can create reflux. Number 2 is go on the right, as Pankaj showed. So sometimes you don't see those vessels at the OG junction. But even if you don't see those vessels, once you are at the LES, you start seeing the palisade vessels at the LES start curving towards the right. Your myotomy starts going to the right rather than posteriorly at 12 o'clock, at 6 o'clock. So don't be at 6 o'clock. Go to the right. 5 o'clock, 4 o'clock, the myotomy. That way you'll not cut your sling fibers. But full thickness myotomy, I mean, we do as a routine. That doesn't increase the reflux.
Absolutely. Any predictors for predicting who would develop a reflex apart from the procedure aspects? Is there any predictors?
Not exactly. But sometimes if you're too enthusiastic while doing poem, I tell you, in one of our cases, I do always a full thickness myotomy. In one of my cases, I enthusiastically cut the diaphragmatic crura also, thinking that it's a muscle of the esophagus. That patient had severe esophagitis, almost developed a stricture in the esophagus. So much reflux because I cut both the mechanisms, LES also, as well as the diaphragmatic crura. So be careful, even by mistake, don't cut the diaphragmatic crura when you do a full thickness.
Please go ahead.
And when the indication that you are cutting the crura would be, you will get twitching on the muscle. If you are cutting the esophageal muscle, there will not be any twitching. This is a very important point. So when you cut the diaphragm, you will see the contraction of the muscle, and then you know that this is the diaphragm. So you stay away from it. Don't cut it.
It's very thick. It's very thick.
It is very thick.
Yeah. In one of those articles, they mention about those endoflip and keeping the millimeters between 4 and 8. They are the ones which has less reflux. But I don't know how practical it is for us. Do you have any experience with endoflip?
No, we don't use endoflip because endoflip can become a little bit expensive. So we have not yet taken the endoflip. But if you follow right principle of performing the procedure, then I think you can avoid reflux in majority of the times.
Apart from the clip and the suture technique, loop technique, there are a few other techniques also mentioned about having a stitch, getting a stitch, and does that matter? Does it matter? Does the results?
Same thing. He himself came up with this new technique because he realized very soon that the loop and the clip technique is not durable. Because how can it hold? Because even when we put clips for bleeding, you see that the clips fall off. Now here, you're just pulling that loop inside the tunnel, attaching clips. Your clips are going to fall off after some time. And it doesn't create so much fibrosis that it will hold in place. See, that is a very active area of the body. There's a lot of movement going on over there. And in that place, that loop is not going to hold. It's going to come out. See, I already showed you results of the surgically created fundoplication. Even a surgically created fundoplication does not last. How is this going to last? It's not going to last. Right. So suturing may be options. With suturing, you will have a little bit more durable fundoplication.
And one more important point is even after LHM with any type of fundoplication, they still have reflux. They still have esophagitis. So I don't think it is always anyway a foolproof method. So you should give only to those who are deserving it rather than do it as a blanket for anyone.
That paper has clearly shown that 50% of patients after LHM and DOR are on PPS.
That's right.
Why? So what are we going to achieve?
And plus, only a fundoplication for genuine reflux without anything also have a lot of incipient complications and problems. So you are just adding to the problems rather than getting a solution for it.
Yeah, so I think we should select your patients and offer them something which is very simple, safe. So even an ARMA procedure, ARMS procedure, a GERDEX may not be possible for everyone because it is expensive, adds to the expense tremendously. So we can do such things, simple things.
Okay.
Before you joined, we are talking about POEM in pediatric population, below 13. So what are the tips when you have to do procedure in children? Anything specific or anything?
Before you answer, what is addition to the same question? See, is there anything we can do in the initial incisions and all those things to prevent more barotrauma and carbon dioxide related, complications in children?
Not only in children, carbon dioxide related complications ideally should not happen at all. The main issue is you should not rely on the tubing supplied by the company. You have to put a small valve between the tubing going to your scope, and you have to regulate the bubbles coming out of your scope. So outside first, you have to check how many bubbles are coming, what are the size of the bubbles. It should be a very slow flow. Don't just attach the tube and then start crying that there is surgical emphysema or there is capnomediastinum, capnoperitoneum. No. Okay, so do it beforehand so that you will never have capnoperitoneum. Very rarely. In children, I'll tell you what, in children, the youngest child where we have done POEM is 3-year-old. But I'll tell you something, that there's not much difference between doing a POEM in children or in adults. But in your mind, you have to shut it off. In mind, don't keep on thinking that you're doing in a child. Then you'll create a complication. In your mind, once you enter the tunnel, it looks like an adult. So keep on performing the procedure as if you're doing it on an adult. Taking all the normal precautions. You don't have to take any other special precautions.
I agree.
Is there, what is the relationship between I was a little confused when I was reading that, this, the initial mucosal incision, smaller and larger, causing, carbon dioxide complications. A larger incision allows easy escape of carbon dioxide into the lumen, or what is it? What is your take on?
No, it doesn't matter. That doesn't matter. That is only if you are not controlled the CO2 flow beforehand. Mm-hmm. For that, if you make a large incision, obviously the CO2 will not collect inside the tunnel. It will tend to go out in the lumen. So that can be one of the via medias. Okay, but that is not a way out. You don't have to unnecessarily cut big because the mucosal incision should be as small as possible. It should be just bigger than the size of your cap, just for you to enter inside. So that you can close it with only 3 clips or 4 clips.
And more important, I think, would be make a little wider tunnel inside rather than just making a small hole. So dissect inside and make a tunnel which is wider. That is more important rather than bigger incision.
How does that help?
Tunnel should be very roomy. I'll tell you how it helps. Because the lower esophageal sphincter tone is not only contributed by the muscle, it is also contributed by the submucosal tissue between the muscle fibers and the mucosa, that areolar tissue what you're cutting. Many times you must have realized when you have done the tunneling itself, if you pass the scope in the lumen, you'll find that the LES is opened, even without the myotomy. Why is it opened? It is opened because you have released the areolar tissue. So therefore, you should always make a wider tunnel. That will add to the success of your POEM.
I think the organizers have given directions to wind up the session.
Okay.
Thank you, Dr. Amit and Pankaj.
Fantastic.
Thank you.
Fantastic.
And let me thank Dr. Manoj and Dr. Avinash for putting up this wonderful program. Thank you once again.
Thank you. Bye.
Thank you, everyone. Thank you. Bye-bye.
Bye. Bye.